Okay, looks like we're all set. Hello, web shadowers. Welcome to summer week 5. Today, we have the pleasure of hosting Dr. Johnson, who will be teaching us about ultrasounds and emergency medicine. We're very excited and want to thank you all for attending our session this afternoon. As always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. With that being said, Dr. Johnson, you can start whenever you're ready.
Cool. So, hey guys, what's going on? I figured today, I looked at some of the previous videos you guys had on the channel, and I figured today we could just try to do like an actual virtual shadowing thing. So it seems as though you have a pretty good idea of what emergency medicine is from some of the videos I watched that are already on here. So there's this game, it's pretty fun. It's called Full Code. You're probably looking at it right now as I'm sharing my screen. And basically what it is it's like simulated emergency medicine cases. So I'm just going to do random cases, stuff I've never seen before. So this will pretty much be like you guys are in the ED seeing patients with me. Hopefully I don't make a fool of myself by not knowing the answers, but please interact with me in the chat. I know it's with the YouTube thing, the YouTube live, it's a little delayed, about 30 seconds. So I'll try not to like leave a lot of dead space of asking questions and whatnot. And hopefully it's pretty fun. Just as we're getting started, I guess, waiting for more people to join, I'll tell you guys a little bit about myself. I did medical school in Southern California at a DO school called Western. Then I did residency in New York City with Northwell Health. And then I just finished, like last week, my ultrasound fellowship here in Detroit, Michigan with Beaumont. And then during the ultrasound fellowship year, what's kind of nice about emergency medicine and ultrasound fellowship is you get to work as an attending. So I got to work as an attending while I was kind of learning more about ultrasound. And then this next year, I'll be here in Michigan working as an attending. And then actually, I'm doing another fellowship for some crazy reason. I just want to continue to never make actual money as a doctor. So I'm doing another fellowship in anesthesia critical care at USC in Southern California starting next year. So I'm excited to be going on to that. Cool. So Brendan said he just applied to Western. So that's how much the chat's delayed. So sorry, guys. But let's get started with our first case. So I think our first one I will jump into and just kind of run through on my own. So you guys can kind of see the flow of the game and stuff. And then after that, hopefully I can get some interaction with you guys as far as what you want me to do, what you think the diagnosis is, and what kind of next problem solving steps you want to do for the patient. So let's get started. So here we go. So random case. Hopefully it's not a peds case or a pregnant lady case. We will see though. All right. So 67-year-old male found by bystanders wandering in the local park. BLS, that stands for basic life support transport, noted that the patient was oriented to person only on scene. 2+ diaphoretic. I'm not sure what they're saying with 2+ diaphoretic, but anywho, 2+ diaphoretic, no facial droop, moving all extremities, acute confusion, unknown, last time well, question stroke to resuscitation base. So this is actually a pretty common presentation, just people found down, you don't know what's wrong with them. So I'll just talking about what's going on here. The first couple things I'm going to think about is this hypoglycemic episode. So I'm going to check his finger stick pretty quickly. Also, is this a head bleed? So I'm probably going to get a CT of his head pretty quickly. And then beyond that, there's kind of some basically like mantras we like to say of emergency medicine that we basically do with every single patient as they get in the room. So I'll go through those mantras, and then on the subsequent cases, you guys hopefully will have those in your head and you can prompt me to do them. So I'm going to click begin here, and hopefully I don't look like a fool. All right, begin. So first things first is ABCs, airway, breathing, circulation. So it looks like this guy's breathing. So I'm going to do the next mantra, which is IV O2 monitor. So over here on my little stabilization tab, I'm going to attach the patient to the monitor, check out his vitals, insert an IV. So let's see what vitals we have. He's not tachycardic. His temperature is 37. He's 100% oxygen on room air, 100 to 98. That's fine. Blood pressure looks okay. And his respiratory rate is 18 a minute. All right. All looks pretty good. So I'm basically not going to do anything for this guy right now, except those couple things I talked about. So I'm going to get his finger stick. Let's see. And make sure that's normal because he's minimally responsive. And let's see. So he's hypoglycemic. So I guess it's good we did that first. So let's give him, we don't know why he's hypoglycemic, but we're going to give him an amp of D50 to correct that. Sorry, this is on my intervene tab. So we already have a line in. So we'll give him an amp of D50. Let's give him that. Okay, so want me to check a finger stick? Yeah, sure. We can check another one. I usually wouldn't check it again that quickly, but let's see what if it's gone up now. Maybe the game will just let us cheat. All right, 119 now. So he's no longer hypoglycemic. So now the next question is, what is going on with this guy? So let's move on to some history and physical. So this is the same thing that was in that kind of pre-hospital thing. All this says unknown. So in this game, I just click all of them. You get more points if you do everything. So I'm going to just click all of them, and then we'll scroll back through and read what his review of systems was. All right, so let's see. Unable to answer due to confusion. So his entire review of systems is more or less negative because he's so confused. So even after we gave him the glucose, it looks like he's still confused. So let's do a full exam and see what's up with that. Okay, and let's see what this says. So we have normal airway, it sounds like, bilateral breath sounds, good circulation, normal head, neck. HEENT is head, ears, head. What is the second E? Head, eyes, ears, nose, and throat. So it's like your full kind of head exam. Neck is no masses. It looks fine. Regular rate and rhythm. Palm, clear to auscultation. Everything is looking normal so far. No CVA tenderness, no clubbing. Diaphoretic and warm. Okay. The thing I'm probably most interested in is a neuro exam. Confused with grossly intact cranial nerves, moving all extremities, unable to follow commands. Okay. So he's kind of in and out of it. So is this tox? Does he have a brain bleed? He's hypoglycemic, so that probably explains most of it. But we're going to get some more tests here. So also like hypothyroidism can cause you to be hypoglycemic. But usually if this was something called myxedema coma, he would have bradycardia and hypothermia, which he doesn't. So let's start building our differential list here. So obviously hypoglycemia is going to be probably number one on here. And then that was another good one on there. They had oral hypoglycemic overdose. So that's basically you take too much of your diabetes meds. Let's see. So obviously head bleed is not on here. So we'll do, there we go. Closed head injury is on here. That's something I want to worry about. He doesn't look like he's septic. So we'll put myxedema coma on here because it could cause it, but it doesn't really look like myxedema coma. Obviously we have toxic ingestion. So let's go down to tox and see what else we have on here. It's not any of these. It could be alcohol intoxication. He doesn't really look completely like it. It's possible. He's not bradycardic, so it's not one of these guys. None of these. Could be ethylene glycol or something. Doesn't really seem like it. But we'll send off serum osms and everything. Okay, that seems like a pretty good list of differentials. So now let's do some tests. Close this tab for more space. So we already did that bedside test. We'll also get an EKG. I don't really see, unfortunately, I don't really see a need for any sort of ultrasound at the moment. Not that I can think of. Lab work wise, sorry, I'm drinking my Kirkland brand iced coffee. It's very delicious if you guys haven't tried it. So we'll see what his pH is. So we'll get an ABG. We'll get a Chem 7. We'll get a tox panel. We'll get a calcium level. We don't know if he's bleeding, so I'll get coag, CBC, lactate. It's probably going to destroy me on ordering too many tests. Sometimes it gets really mad when you order too many tests. Sometimes it thinks you ordered a good amount of tests. So I don't think it's sepsis, but we'll get some of that stuff. Some of the weird things I think I'm going to get on him is probably like serum osmolality to check for toxic alcohols. We'll check a TSH on him, even though I don't think this is myxedema coma. We'll check a urine tox. And then for imaging, we're going to get that CT head, right? So where's the CT head? Obviously. Since he's found down, I usually put a C-spine on there. I have a feeling they're going to tell me, I think they're not going to like that. So I'm going to take it off because he doesn't have any signs of trauma, but usually I just get a CT C-spine on anyone who's found down. We'll get an X-ray of his chest. And now let's see what comes up. You guys have any guesses? No one's in the chat really talking. Hi, Giselle. So let's see if you guys have any guesses before I'll click perform on here. All right, so let's see what this EKG shows. So EKG looks pretty good. So we just got, these are P waves. QRS and a T wave. So the first thing you want to do whenever you're looking at an EKG is just see if there's a P before every QRS. P should also be upright in 2 and down in AVR for a normal sinus beat. Looks like that's, I think my chat's messed up. All right, there we go. It's on live chat now. Sorry, guys. Doesn't look like there's any updates anyways. Okay. So this looks like normal sinus rhythm. I don't see anything concerning there. So let's see. Chest x-ray looks pretty normal. There's a little peribronchial cuffing there. I don't see any effusions, no signs of trauma or anything. CT head. Did they let you scroll through the CT head? Oh, well, so this is not a live image of a CT head, so it's not super useful, but I think it comes with an interpretation. Normal without evidence of mass or hemorrhage, so that's good. No brain bleed. So negative urine tox. TSH is normal. Osmolality is normal. So his urinalysis, a little dehydrated, no ketones. His urinalysis is pretty normal. Phosphate, all this is normal. All this is normal. Looks like he might have just had hypoglycemia for some reason. He's also a little drunk. So serum osms are, so his ethanol level's up. So he's obviously a little bit intoxicated, mildly hyponatremic. So his sodium's a tiny bit low. Glucose is elevated now that I gave him that amp. pH is okay. So, this guy's pretty much, I don't think he needs to be put on anything. Let's recheck a finger stick. I don't know why he is like the way he is. Why? It's just because he's drunk and hypoglycemic. So his finger stick's still good. It's 119. So I don't see a reason I can't admit this guy. Talk to the patient's husband. There you go. That's usually not there, so that's new. The patient has a history of mild dementia and is on glipizide, 10 milligrams every day, aspirin and ginkgo. The pill dispenser has 5 missing days of pills. All right, so that glipizide, that's an important one. So that's a sulfonylurea. So that will make you persistently hypoglycemic. So sometimes when you have hypoglycemia, like you can send these people home because, it's just they forgot a meal and they took insulin or something like that. But this guy is probably going to be persistently hypoglycemic. So I would want to give him food if that's an option. I don't know if I can feed him. Is that on here? Meds miscellaneous? Because that will definitely help. It's not on here. So I think I could probably just admit this guy. And so I'll consult endocrine, have them see the patient inpatient, spot cortisol and TSH on the patient if they're failing to thrive. I don't think that's indicated. So usually they just get an inpatient consult. I will say this guy, I would admit him to the floor for hypoglycemia, oral hypoglycemic overdose. So let's see how I did. Let's finish. So, all right, 90%. Not too bad. So it says that I did poorly on interventions and communication. So let's see what interventions it thought I needed to do. So it wanted me to give an octreotide bolus. So that's interesting. I don't think that this guy would have necessarily indicated an octreotide bolus. So now that I'm seeing this though, I'm assuming the communications tab they wanted me to do is to consult toxicology. So what octreotide does is it actually blocks the calcium channels in the pancreas, and it basically stops you from further releasing more insulin. So the reason that the sulfonylureas cause the release of insulin is they hypersensitize the pancreas to release more insulin. So giving octreotide can stave that off. But in the majority of cases I've had of sulfonylurea overdose, if you're able to correct the patient with a D50 bolus, and they don't continually drop and drop and drop, tox does not want you to give octreotide. I'm not really sure off the top of my head what the downside to octreotide is, but that's just the experience I've had. So I don't think I would have given octreotide in this case unless tox told me to do that. And this communications that we got 50 on, I'm sure, is they wanted us to consult tox. Talk to patient's husband, consult endocrine neutral, consult toxicology. So yeah, plus or minus. I feel like this is a pretty common case that we deal with without toxicology. If they were persistently hypoglycemic, I definitely would have put a call in to tox for some more ideas, but I think we handled this on our own. Okay, well, that's pretty good. Let's see. There's someone ask, which tests do you decide to check first when you have a patient? So I think that this game is like a pretty good example of that. Is all the tests that you get are very dependent on what you think the diagnosis is and what you're looking for. So I think that, when some people who aren't in medicine think about medicine, they think about it from like the show House perspective, where we just have this unlimited amount of tests we can order at any time of the day, with no worry about who's available, what's available, and what it costs. But in reality, every test has a cost associated with it, and some tests need specialized equipment or specialized personnel to perform. So you really have to kind of try to do the minimum amount of testing to secure your diagnosis and be confident in your diagnosis, in order to safely take care of the patient, while unfortunately saving money for the hospital and the patient, and acknowledging the resources that are available. Like, say that we were at a tiny rural hospital in the middle of nowhere that didn't have an MRI. What are we going to do to get that patient to an MRI if they need it? What are we going to do to make sure they don't need an MRI if they're kind of on the borderline? Yeah, it's kind of like that. So let's see, Aaron B. What were all of the mantras that you used? So far, I've only used 2 mantras, but the first big one that everyone's going to probably hear in all of their BLS classes, their ACLS classes, any sort of emergency medicine setting is ABCs, and that's airway, breathing, circulation. Basically, so there is some nuance to this. Anyone who's like a little further along in their education will know that in trauma, we use something occasionally called March, which we kind of deal with massive hemorrhage first. But that being said, the ABCs is pretty universal, and everyone kind of accepts it. Airway, breathing, circulation. So what that means is, first, when the patient comes in, do they have an airway? The easiest way to quickly assess whether a patient has an airway or not is, can they talk to you? If a patient can phonate, if they can make words with their mouth, then they're able to pass air through their vocal cords, and they more or less have an airway. Now, the problem is that doesn't say everything, right? So you can be so tachypnic, so you're breathing so fast that you're not going to be able to keep up with that. And that's kind of where the breathing component comes in, because sometimes we still have to intubate people and do things for that because they have working too hard to breathe. But the airway is the first step. So can they talk to you? Breathing, do they have bilateral breath sounds? Is their rate acceptable? Is their oxygenation acceptable? And then circulation is, do they have a low blood pressure? Do they have a high heart rate? Kind of like that. So that's the ABCs. And then the other mantra that I used was IV O2 monitor. And that's something in emergency medicine that we kind of use for oral boards. So this is kind of like oral boards where some specialties have oral boards, some don't, but we have to do oral boards where like a test administrator will present a case to you orally, and you have to basically verbalize what you're going to do. So IV O2 monitor is kind of the beginning. I'm going to put an IV in the patient, establish IV access. I'm going to connect the patient to the monitor. I'm going to put the patient on O2. Obviously, every patient doesn't need O2, and every patient doesn't need an IV. But basically, if you're hitting up the emergency department, you're probably going to get an IV. That's kind of just how it goes. Other stuff on here. Yeah, this is a cool game for sure. It is called Full Code. That's correct, Full Code. Yeah. All right, cool. So I would love it. There is a bit of a lag here, but I would love it if we could have a tiny bit more interaction from you guys as far as like what you think you want me to do. So it's a little more like shadowing. I would love to just keep going through cases and teaching you guys, but I'll pull up another random case here, and I'll try to go a little bit slower. So when you guys are done reading the case presentation thing, try to like put in the chat what some of your differentials are, what some of the first couple tests you think I might need are, and then we'll go from there. And also, if anyone like wants me to do something else, I have a ton of ultrasounds I can show you guys and just chat about. But I figured this was pretty cool. It's kind of like you're shadowing an ER doc. I know that a lot of people like give you guys talks on the ER and all the cool procedures and stuff we get to do. But one of the things that really made me fall in love with emergency medicine to begin with is like, we're kind of like the detectives, you go through med school and you learn all these cool diagnoses and how to figure everything out. And in all honesty, there's not a lot of places in the house of medicine where that happens. The ER is pretty much the place where you get to deal with all these acute emergencies and acute undifferentiated patients and try to figure out what they're doing. Jane wants me to do a pediatric case. How about I'll do one more random case, and if it's not a peds case, I'll choose a peds case. I will say that things that are harder for me are pregnant women and peds. So I'll do one though before we're done. So I'll do another random one then, and then we'll see if I get a peds one here. I might. That's a 47-year-old male. Sorry, Jane. The next one I'll specifically choose peds. All right, so you guys read through this. I'll read through it a little slower so that the lag maybe will catch up with me, and you guys try to see what you think about what tests I should order, and maybe even if you have an idea of what the diagnosis is. So we have a 47-year-old male found seated at work. He's drooling, coughing after drinking drain cleaner. Okay, well, so this kind of is a case where there's not much of a differential. Sounds like we know exactly what's going on with this guy. Awake with a hoarse voice. His blood pressure is 155/90, heart rate is 125, saturation is 87% on arrival. So male toxic ingestion. It's kind of blurry. Is there any way, let me see if I can make it better. Toxicology. Is it blurry for everybody?
It's fine for me.
Okay. Well, maybe it's just that their YouTube connection. Let me know if it looks like I can't really change. I already put on the video settings and stuff. But yeah, good. So you guys are saying ABCs, IV tox screen. So call poison control. Nice. These are all great recommendations. Oh, it's pretty blurry. Yeah. Wonder if I could change it. Nope. Someone says nope, not blurry. Toxicology. All right. Well, hopefully it's not. It's just some people's internet connections. Psych should be consulted at some point, I guess. So first things first, when we walk in, we said ABCs, right? So what is this, just this case presentation right here? Does this sound like an A, airway? Does this sound like this guy's airway is intact and he's going to be okay? Or does this sound like I need to walk in the room and intubate this guy? I'm leaning towards I'm going to be walking in the room and I'm immediately going to be set up to intubate this guy and put a breathing tube in him because I don't think he's going to handle breathing on his own for too long. So let's go. Let's get started. So this is kind of one of those crashing patients that I feel like even in the game I get a little nervous about. So I'll probably run through things quick. So if anybody needs explanation on stuff, let me know. All right, so here we go. So walk in the room. What do I do? ABCs. So I already decided his A's are bad. So I'm going to stabilize this guy. So I'm going to attach him to a monitor. I'm going to insert an IV. He is a SAT of 87. So I'm going to put him on something. I'll put him on nasal cannula for now. Pre-oxygenate before you intubate. The other thing you want to do is make sure that blood pressure is good before you intubate. So his pre-ox is going up with that nasal cannula. Now let me just do a quick airway exam. So drooling and stridor, this guy's going to get tubed. So I am going to paralyze and intubate him. So we'll go to our intubation stuff here. So we are going to get our positioning for intubation, prepare our endotracheal tube, suction. He's pre-oxygenating already. And then what do we want to give this guy? I am going to paralyze him with a rock. Yeah, okay, I'm going to go with rock. And then I'm going to sedate him. I think etomidate is probably what I'm going to go with. And then his pressure is good. I think I'm going to use rock and etomidate. So that's what I'm going to do. So we're going to go ahead and intubate him. Positioning for intubation here. Now we are going to prepare. Suction is set up. We're pre-oxygenating him. They gave him the paralytic. Oh, they gave him out of order though. Always sedate before you paralyze. Okay, so he is now intubated. So we've secured his airway. So that's good. And now a lot of you said tox. So not really. So this is a caustic ingestion. So we know that he drank something caustic. So do you guys have any other, I'll do other stuff while you guys are thinking about the answer, but do you guys have any other ideas about who else I should be contacting besides toxicology? Because I don't think tox needs to be involved. Okay, let's see what the chat says. Intimation. Is the blood pressure high? Blood pressure was high, but in this case, I like it high because I'm about to intubate him and paralyze him, and he is going to go lower probably. How are you discerning paralysis drug for intubation? Okay, so here I chose rock. So the two big things that we do in the ED are either sucks or rock. Rock lasts longer. It has a lot less side effects. A lot of people say sucks, which, is funny, but there are certain situations where I would use sucks. So I was just kind of running through my head all the contraindications to using rocuronium, making sure that he didn't have any of those contraindications for rocuronium. For rocuronium before I used rocuronium. Sorry, I was getting a phone call. And but basically, there's a lot more contraindications to sucks. So rock is almost always the right answer. Oh, wow, you guys got it all right. GI. So why do I need to GI? CT of the abdomen. I probably won't get one. Cardiology, GI, neurology, any neuro damage, neuropsych. GI is the correct answer, and that's because they need to do endoscopy and see how much damage this thing did. But let's see what else we got on physical exam here. So he's intubated, good. Peripheral pulse is good. Normal cephalic, good. No bleeding, no masses. Tachycardia. Transient upper airway sounds, no retractions or wheezes, rales, rhonchis, diffuse tenderness, mild distension, normal active bowel sounds, no percussions. So now that I see this, I probably will get a CT abdomen pelvis. He's diffusely tender, so he might have a rupture from this. So I'll probably get a chest X-ray and a CT abdomen pelvis. No CVA tenderness, no intubation. Okay. GI needs to pump the stomach. It's a good thought, but no. Usually taking stuff out is almost never the option almost never the best thing when it comes to tox. Because if you can imagine, this was a toxic ingestion. Whatever you bring back out is probably just going to cause more damage. So it's usually either neutralization or just assessing the damage and trying to repair it. So we've done all of our stabilization stuff. So here we're going to do caustic ingestion as a differential, obviously. He's still tachycardic. He's not febrile. He's not hypertensive. So ENT, does it burn esophagus? Yeah, so ENT is a good thought, but no, usually GI would deal with this. ENT usually doesn't really touch this kind of stuff. Would the substance that he drank be in his excretory system? Good thought, but kind of it should already be neutralized. The caustic nature of it should have already kind of destroyed the local tissue, and it doesn't really. So the problem with caustic ingestion is whatever it touches, it harms. So you can imagine that the harm's already done. So anything that like a chemical that got absorbed subsequently wouldn't harm any of the downstream like organs. So caustic ingestion. Let's see what else. Overdose, is that just a straight overdose? Not really. Do I really have any other differentials for this guy? I mean, I guess perforated viscous. Is that a thing on here? Perforated, not an ulcer. I really don't have a lot of other differentials for this guy. I kind of know exactly what's going on. So let me see if there's any, like, the more stuff I get on here, the more points I get. I want to try to maximize my points. That's what medicine's about, maximizing your points. I'm just kidding, by the way. Crohn's, diverticulitis, esophageal foreign body, esophageal rupture, so that's a concern. GERD, incarcerated hernia, none of this stuff. Perforated gastric ulcer, not really. Yeah, none of this other stuff. All right, cool. So what are we going to do to investigate? I don't think he really needs, so we're going to get an EKG. I don't think he really needs a tox screen. I don't really think he needs an aorta. We could do a fast, see if he's got free fluid. But I don't think that's going to help. Usually ruptured viscous is one of the limitations of fast. You don't normally see free fluid or anything on the fast because ruptured viscous usually causes air to be in the abdomen and not fluid, and fast detects fluid. Fast stands for focused abdominal sonography in trauma, and it basically just looks for free fluid in the abdomen. Samantha asks, how would GI neutralize this exactly? So, I don't, now that you mention it, I feel like I remember reading that GI doesn't normally neutralize toxic ingestions. They just kind of go in afterwards and kind of like look. But that is somewhere where I think that now that like this guy's intubated, his airway secure, I probably would ask Tox that question. So let's see what Tox says. They just say consult GI. So yeah, I don't know. I'll have to look it up after we're done with this case. We'll look it up in the other tab. That's what I do. That's what I normally do at work when I don't know something. I just look it up. That's the beauty of the internet. All right, so we're doing those things. Let's get lab work. So We're going to get, we'll see what his pH is. We'll get a serum tox, even though I don't think it's going to be super helpful. He might have to go to the OR, so I'm going to get a blood type and screen, and I'm going to get coags on him because he might have to go to the OR. CBC, LFTs, yeah, mag, phos, okay, and that's good there. And then I don't think he needs any weird labs. I don't think any of this is going to help me. I guess maybe if he has a co-ingestion, but I don't think he does. I think he'll give me points off for that, so I'm not going to do it. We'll get a urine tox. And then now that he's diffusely tender, I'm going to get that chest x-ray and a CT abdomen. So chest x-ray will basically show me if he has, we have to get it for two reasons. One, we have to confirm how deep the endotracheal tube is. You always have to get a chest x-ray to confirm ET2 placement. The other thing is we need to get an idea of if he has an esophageal rupture. We should see like pleural effusions and stuff like that. All right, so there we go. Tox says that. So let's do our intervention, see what comes up. Investigations rather. Let's see. All right, EKG. EKG is oh, I have it on like the medium setting, so it's giving me interpretations down here. I should change it to hard so you guys see me really sweat a little bit. I have to interpret everything myself, but it's telling me it's sinus tach. So I mean, it's sinus tach. I don't see anything on here. P waves, QRS complex. Looks like all the T waves are going the right direction. All the P waves are going the right direction. QRS is good. Okay. Chest x-ray. Now that looks, they're saying normal lung fields. This looks pretty fluffy to me. This looks like pulmonary edema. So yeah, I don't know. I would have said that these lung fields look abnormal to me. They look pretty congested. But I mean, I can't really tell if there's like, it doesn't look like there's a big effusion though, or anything. The mediastinum doesn't look wide. So I wouldn't say there's like signs of esophageal rupture, the thing that I kind of ordered it for. But I would say the lung fields don't look normal to me, but the computer says they do. So I guess I'm wrong. CT abdomen and pelvis, no evidence of gastric perf or free fluid, no solid organs. So obviously this is a still image. So even on the hard mode, they just give you an interpretation because you can't scroll through a still image. Okay, let's see. What will a pH tell you? So my only thought with the pH is if there's co-ingestions that are making him acidotic, that might give me a clue. So basically, I'm kind of ignoring the fact that he drank something presumably trying to kill himself. I'm ignoring the fact that maybe he did other stuff, which is not good. You should always consider, did he do other things to try to kill himself? Because while we're taking him to the gastro suite to try to fix this esophageal burn, like his metabolic acidosis could be getting worse and worse from all that toxic alcohol he drank or something like that. So that's why I got the pH, is more for a screening thing. And would you ever administer charcoal, or is that for toxic ingestion? So I usually never administer charcoal unless tox tells me to. And usually charcoal is given to actually, so the thing that people kind of think in their mind about charcoal is like syrup of ipecac. Have you guys seen that? It's like where you throw up. It makes you vomit. But what activated charcoal actually is something that you put into your stomach. You have the patient drink that actually binds whatever's in the stomach and basically makes it inert so that it passes through the gastrointestinal system without getting absorbed systemically. So there's only a handful of things that actually get bound up by charcoal, and you have to be pretty quick on it. So basically someone has to have taken it before the contents passed out of the stomach. So it's kind of like, it's one of those things that I don't know all the ins and outs super well because it's not something I deal with on a daily basis. So I usually call the experts for help. And Tox, out of all the consultants you deal with in the ED, Tox is like some of the nicest people. First of all, because they're also ED docs, so they're really nice to begin with. In my opinion, we're all very nice. Some of you may feel differently, I guess. But on top of that, the tox guys, like, they deal with this stuff all the time. So off the top of their head, they already know, oh, that charcoal will work for that, and the time of ingestion's X, so you should give it. And then they'll tell me the dose, and I kind of offload some of that stress. Everything you do in the ER is about cognitive offloading. If you have a consultant or an assistant, like a respiratory therapist, I saw someone put respiratory therapy in the chat. If you have someone that can cognitively offload some of these tasks, especially with a super sick patient, so that you can focus more on the big picture, then I think that that will make you a better ER doctor. So I always call consultants that I know are experts that can help me quickly, so I don't have to think about it as much. So I would call tox, before I give activated charcoal most of the time. Unless I was somewhere I wasn't able to call tox, like we were talking about before. Some places don't have those resources. Fortunately, tox usually has a national hotline that you can call, but like sometimes you don't have GI on call 24/7. Sorry, I'm nervous, so I'm getting that like cotton mouth. I'll calm down as I get more into the flow of things, I guess. So let's see. Tox screen's negative. FOS, MAG, normal. LFTs are normal. CBC is normal. Coags are normal. He's O positive. So the only reason I got the type and screen in the coags is because if he needs to go to the OR, then they'll want that stuff. So I just got that for that reason. Well, not if, he does need to go to the OR. CMP is normal also. No alcohol or anything. pH is normal with the normal CO2 and oxygen. There's no stripe in the bilateral upper quadrants, pericardial effusion, or fluid behind the bladder. So like I said, the fast probably wouldn't have helped us anyways, and we got the CT anyways, so didn't really need it. So at this point, he's still tachycardic. I'll probably just give him some fluids, which I should have done way earlier. I'll give him a little bolus of LR. He's probably tachycardic because I also have not sedated him. So that is the other thing that you always need to remember. I've been distracted by this game. So this guy's now intubated. Rocuronium lasts longer than rocuronium, the paralytic that I used, actually lasts longer than etomidate. So etomidate is pretty short acting. And there's actually a recent trial that just came out in Annals of Emergency Medicine. It was called the awareness trial or something, talking about how often, you guys can imagine, I'm sure this is like horrifying, how often we paralyze someone and we forget to sedate them adequately afterwards. So you're laying there with this breathing tube in and you are literally cannot move and you're awake. And so like that's a nightmare situation. And this trial basically said that it happens more frequently than we'd like to admit. So I literally did it to this patient, unfortunately, because I got distracted by all the other stuff. So this guy needs to be on a sedative infusion. So I'm going to bolus him with propofol, and I'm going to give him a propofol infusion. And I'm also going to start him on something for pain because I'm sure that esophageal burn is very painful. So I'm going to give a bolus of fentanyl, and then I'm going to give him we don't have a pain infusion on here except ketamine. So I guess I'll give him a ketamine bolus and infusion instead. We don't have any other pain infusions I see on here. Nope. Okay, so we're going to go do that. So we're giving him all that. So his blood pressure, his heart rate should come down a little bit now because, hopefully, we'll see how accurate the simulation is. But basically, I'm going to take away that anxiety and everything of being, in pain and paralyzed. And I'm just going to basically make him dissociated so he doesn't remember any of this stuff that happened. Because obviously that's our goal. Like, we don't want him to suffer while he's laying there and we're trying to fix him. So I'm going to call GI. Let's see what GI says. Oh, it's already done here. The gastroenterologist says that the drain cleaner can cause severe esophageal injury and potential perforation. Nice. They will see the patient after they are admitted and will plan to perform a delayed endoscopy. That sounds like a good plan to me. So where do you guys think this patient should go? He should be going to the operating room, discharged, admit to floor, or admit to the ICU. And then what is our diagnosis? I'm going to put as caustic. This case has 2 correct diagnoses. What? What's the other correct diagnosis? Didn't have a perforation. I didn't do a CT chest. He drank drain cleaner. Yes, good job, Navya. Sorry, I don't know if I'm saying your name right. He needs to go to the ICU. I will put that here. But then what's the other diagnosis? Not the OR. I would have said, yes, I would have said OR, guys, if GI said they're going to take him to the OR. But GI said they will see the patient after they are admitted and will plan to perform a delayed endoscopy. So they're going to do it later. So technically he'd be going to the SICU, I think, which is the surgical intensive care unit. But nonetheless, the ICU. So what's my other diagnosis? Should I get a CT chest? I'm going to get a CT chest because I think there might be a perforated esophagus. Can't talk. Sorry. A perforated esophagus that I have not diagnosed yet. You don't always see it on the chest x-ray. So let's see what our CT chest says. CT chest, no evidence of esophageal perforation or free fluid. What? So what's our other diagnosis? Choose one more diagnosis. So there's no rupture. A psych. Oh, you're so smart. Almen A1C. That's a funny name too. You're so smart. I bet you it is suicidal ideation. Is that a thing on here? Nice. You're so smart. Let me go find it on here. Tox. You guys see psych on here? Hematology, neurologic maybe? Ischemic stroke, migraine, yes. Huh, I do not see a psych stuff on here. Any other thoughts? I guess I'll just get it wrong in a minute and we'll find out for sure. What other stuff is on here? Allergy, immune, environmental. The more communication, I don't think it was anything important. I think that was like, it was the one that I called tox or whatever. I mean, it was important, but they already said can cause mucosal injury, necrosis, they can gastroenterology. That's basically all they said. Well, I guess it's not on there, so I'm going to have to say I'll just hand them off to the unit and see what I got wrong. We're going to admit to we're going to admit him to the ICU. And oh, this guy, talk to coworker. Patient drank approximately a quarter gallon of bottle of 6% sodium hypochlorite. So what do I know about sodium hypochlorite? I feel like there's something in my mind about sodium hypochlorite that I should be. I mean, I think it's just hydrochloric acid, but I'm pretty sure it's just hydrochloric acid. But his phos was normal, right? Because that phos and calcium, did I check those? Because that can be, there's some acids that cause, but I think that's the ones that are phosphoric acid. Phosphoric acid will cause the hypocalcemic stuff, but let me just make sure that those are, that I checked them and they're right. So I check mag and phos on here. But I did. Oh yeah, mag, phos, and calcium is on here too. Calcium is normal. Yeah, so it's not that. All right, guys, I'm gonna give up. There's no psych option, y'all. Electrolyte imbalance. Nah, I'm gonna give up. What was the last thing there? It's bleach, 6% bleach. Yeah, I think you're right. Yeah, it's bleach. But basically, household bleach doesn't cause any problem at all. Let's hand off. Household bleach is a very low percent. That's why they commented on the 6%. So it says I have to choose one more diagnosis. So I guess I'll choose esophageal rupture. Hand off, see what I got wrong. All right, 81%. So that diagnosis they said was wrong. So let's see what we did pretty good on this one though. Do a renal consult. Oh, sorry, I already clicked. Why though? Why renal consult? Let's see, maybe you're right. No, communications, I got 100%. All they wanted was tox and gastro, which makes sense to me. Let's see. So what were my diagnoses that were wrong? Investigations. Did I miss anything? They said my urine tox was unnecessary. I didn't miss anything. They just said the urine tox was unnecessary. Neutral on all this stuff. They're neutral on the ABG, which makes sense. So wait, it's not even telling me what the spoiler alert. Yes, I understand. Show me the answers. Severe injury to the esophageal caustic regions, like alkali ingestion. Was it something else? It doesn't really just tell me on here what the. I don't want to read all this. This is too many words. Alkali induced injury, chest X-ray. Well, I'm very confused now. Anybody see on here how I could see what the diagnosis was easily? See complete details. Categories, chief complaint, tox, psychiatric problem. Maybe there was a psych that I missed. I don't know. Oh, it says it right there. So you guys, someone needs to remind me every like 5 or 10 minutes to read everything. Right there, it says corrosive ingestion. So I just put caustic ingestion, and it also wanted me to include corrosive ingestion. So fair enough. Basically, more or less the same things in my eyes. That's funny. Yeah, you're right. You're right. I did not read carefully. Okay, so we'll be done with that. So what did I promised somebody that I do a peds case. All right, I guess here goes a peds case. We'll do a random pediatric case. Let me know when you guys are all ready for it. We'll try to do the same thing. I'll talk about, let's see, I got some WhatsApp messages, sorry. I'll talk about, okay. I'll talk about we'll do the ABC stuff, and we'll talk about what to do first. All right. Okay, it doesn't give me, oh, down there, it gives me an age. It says, presents to the ED via private car with her parents. 5-year-old girl presents with parents with 4 days of cough, fever, and low energy to the point of lethargy. Her parents have noticed that she is short of breath with exertion, sick contacts at school, 2 episodes of diarrhea, no vomiting, and her fever responds to Tylenol. All right, cool. I was born ready. I like that, Emma. Let me see. Is there any difference between caustic and corrosive ingestion? Yes, there is. Let me think about it for a second. So I mean, the difference between like an acid and an alkali is kind of the type of tissue necrosis it causes, which is important. But caustic versus corrosive, I mean, corrosive is basically like it eats through the tissue. Caustic, I just think, is anything that causes damage. But someone Google it, I guess. I guess I could just Google it and see a definition of caustic versus corrosive. Let's see. Was it coming up? Corrosive. So corrosive is eating away. Caustic is capable of burning, corrode. So it's kind of the same-ish. Yeah. And then how long would these take in real time? Pretty long. So, I mean, that guy would have been pretty quick because we kind of knew what was going on. It's like caustic ingestion. We tube him. We get all the stuff going. We call GI. GI's on their way in. We stabilize him. He goes up to the unit. Probably an hour, maybe an hour and a half. But like some that need more workup would definitely be there for like multiple hours. But for real though, aren't these COVID symptoms? Yeah, this could be COVID. We'll see. Okay, anywho. So 5-year-old presents with 4 days of cough, fever, low energy to the point of lethargy. So lethargy is never good. Lethargy is always bad in a kid. So the first thing I'm going to do is what? ABC's IVO2 monitor, right? Attached to monitor, insert IV. So we have a 93 sat, 125. So that might be hypotensive for a 5-year-old. Another reason I'm bad at peds. I think she's tachycardic and hypotensive, but I always look up peds vitals. But 5, that seems low to me. So I'm just going to give her a 20 cc per kg bolus of LR. So there we go, right there. So I'm going to give her that, see if that brings her heart rate and stuff down. I'm also going to give her, she's 38, so she's febrile and pretty tachypnic, not hypoxic, borderline hypoxic for her age. So I will start her on a nasal cannula. And then I'm going to give her some Tylenol because she's febrile. And we'll see if any of that gives her. Oh, it must be under acetaminophen. Acetaminophen. There we go. So we'll give her some Tylenol and bring her fever down, hopefully, and give her some fluids and hopefully bring her pressure up. She's on the oxygen. She's now 96. Yeah, cool. So yeah, pneumonia is a good idea. So this is one of those patients that she's like not about to die in front of me. So I'll do a quick airway exam and I'll make sure her airway's intact, and then I'll get a history and physical. So let's see, airways patent without obstruction or stridor. Right, cool. So now let's get some history. So this is kind of more like a normal ER patient that's like kind of sick. We have some time to talk to parents, to talk to the kid, see what's going on. We'll go from there. So 5-year-old female, cough, fever up to 103.7 for 4 days. She's really tired, has been sleeping most of the day, appetite's decreased. So far just sounds like a sick kid. 2 episodes of diarrhea, cough is productive, small amount of phlegm. She told the parents that her tummy and everything hurts. There are sick contacts at school. She returned to school for 2 days after Christmas break, got sick and has been home now with fever, no rashes. Immunizations are up to date. Her family did not get the flu shot this year. Her parents are worried as they have never seen her sleep so much and they have little energy. She looked like she was having trouble breathing when they walked her to the bathroom. Okay. No meds, no drug. Lives with their parents, older brother, 2 dogs, attends kindergarten. Let's see, chest and see if it's clear. Whooping cough, pneumonia, bronchitis. Does pertussis cause diarrhea? Yeah, usually I think of more viral stuff when I see like the multi-system involvement. The diarrhea one that we usually talk about is like Legionella. I don't think pertussis usually causes diarrhea. And I don't think this kid has Legionella, but maybe. That would suck. All right, let's do her review of systems and see what we got on there. And maybe that will help us out a little bit. Sorry, I'm just clicking through all these so we can go read them all at once. How did you know that you could take the stress and intensive of emergency medicine? So I don't think, I mean, I guess, I don't know. So actually, I think this is kind of a silly answer about that question. How did I know I could take the stress and intensiveness of emergency medicine? This is kind of a silly answer, but I worked at Chili's, the restaurant, before I went to medical school. And it's kind of like working in the ER. There's like a lot of people like hassling you to do stuff quickly. Obviously, it's not life-threatening and it's not really important in the scheme of things, but a lot of people at that job like get really stressed and worked up and like can't handle the like multiple people yelling at them and telling them to do stuff and like kind of just the workflow. And I felt like I was pretty good at it and I handled it well. And I always got good feedback from like my customers and my management. And it just kind of let me know that I was pretty good at handling those kind of like multitasking, somewhat stressful situations. So I already had that idea going in. And then during med school, you do rotations and everything. And so I liked it in med school. And then I thought, yeah, this is what I want to do. So that's the answer I have. But I'm sure there's some people that never worked at Chili's. And I'm sure they knew they wanted to be ER from the beginning also. But that's my answer. All right, let's look at this ROS. So fever, no conjunctivitis. So that's good to note because there's some upper respiratory, mostly viral stuff that will cause you to have conjunctivitis. Nasal congestion, shortness of breath, cough, diarrhea, vomiting. Okay. No change in behavior. So she has no pain or anything. That's good. In her belly, no anemia. Right? Her GI said diarrhea, no hematemesis. Yeah. Okay. Oh, this is more ROS. Sorry. So we'll see what our exam is like. No extremity pain, no hives. Okay. So now let's do a full exam. Let's see a couple more questions on here. ABG. I usually don't get ABG on kids. Usually it's more to tell me pH if I need a pH for some reason. And hypoxia, I usually, especially in kids, can just go off the pulse ox. Hypercapnia is also a reason to get an ABG if their CO2 is elevated. And she doesn't probably have COPD, so I don't think she's hypercapnic. I did not do a gap year. I just kind of went straight through. I actually took like kind of an extra year in college. I started at like a community college and then didn't get the classes I needed. So then I went to like a private college to get the classes I needed, but I didn't take a gap year or anything. I just took like under my bachelor's degree took me like 4.5 years. So let's do these. Yeah, I just pretty much went straight to. I just turned 32 4 days ago, June 25th. So I feel like I'm getting old now, but I guess I already finished residency and 1 fellowship, so not too old. All right. Let's see what we got here. Bilateral breath sounds. Cap refill is good, so her circulation's good. So maybe this pressure is normal for her age. That's fine. Mucous membranes are dry, so she is dehydrated, suggesting to me. No masses, trachea midline. That C sign, tenors, tachycardia, regular rhythm, tachypnea, bronchi and rails. So we should get a chest x-ray for sure. It sounds like she's got abnormal lung sounds. No focal tenderness. That's good. Normal external exam. Hot and dry, no rashes. Somewhat lethargic, speech clear but slow, intact. So, okay. So I'm pretty confident that this is just like sepsis. So let's see what else is in the chat. Yeah, age doesn't really matter. So if you're like old and applying, then whatever. Like being a good doctor has nothing to do with how old you are. So 23-year-olds can be a good doctor and 55-year-olds can be a doctor and just have to be committed. Let's see. I'll answer some of these questions. Sorry, they're unrelated to the game. My schedule's pretty good. It's kind of ridiculous right now. I only work like 8 days a month. But I do a lot of research and stuff and do a lot of resident education stuff. So I kind of work more than 8 days a month, but clinically I only work about 8 days a month. Let's see. It could be adenovirus. And then DO versus MD, it was more location wise. So my wife is a physician also, and she was a year behind me. So, and we grew up in Southern California together. So we both basically wanted to stay there with our family. So I applied only to like the Southern California region. And obviously MD schools are more competitive than DO schools, and the Southern California region is very competitive. So I just didn't get into any of the MD schools in the region I wanted to go to, and MD versus DO didn't matter to me at all. Like I grew up like knowing a bunch of DOs, and they seemed like good doctors. And like when I did a little bit of research, it seemed like it didn't matter. And I mean, emergency medicine's not, it's getting more competitive, but it wasn't really bad for me to get into ER. And then my wife's actually probably one of the most competitive specialties. She's an ophthalmologist, and she matched into ophthalmology out of a DO school. So you can definitely do it. It just takes hard work. She's way smarter than me. So that helps. But it just takes hard work and persistence, and you just have to be committed to your to keep trying until you get what you want. All right, sorry, I've gotten distracted from this. Sepsis. So this looks like she could be septic. So I'm gonna put that on here. And I think pneumonia is a good one. Community acquired. Viral could also be on here. What other stuff do we have? So it definitely sounds like it's respiratory. So let's see what other stuff we have in our respiratory. Let's see what's in our infectious disease. Oh, we'll put COVID on here, but we didn't isolate her. So they're going to be mad at us. Then let's see. She doesn't have any of the rashes or anything, so I don't think that is any of that. Malaria, measles, don't think it's any of this. Meningococcemia, nope. Don't think it's any of this. It could be pertussis, but I don't think so. It doesn't really, I'll put it on the list, but I don't think it's pertussis. Doesn't sound like rotavirus, doesn't sound like scarlet fever. There's a lot of stuff on here. Viral URI could also be there. So then, okay, what am I missing? I don't know. I'll add some more differentials in there. Let's see. I'll finish this case, and I guess we could just chit chat for a bit. It's already 4:57. Is there any time we need to be done by, or do you want me to just go forever?
You can keep going whenever you're ready.
Okay. Yeah, I mean, whenever you guys want me to be done, also I can be done. But after this case, you can pause for a little bit and just chat about stuff. It seems like people have questions. So all right, I'll get some stuff on here. So it said she wasn't wheezing, right? I can't remember for sure. Because I just want to make sure this is, yeah, so they're just saying that it's probably pneumonia. I just want to make sure it wasn't. Let's get a lung ultrasound. That'll be good. And then we'll get just some talk stuff here. So I don't think an ABG is necessary, really, like we discussed. She should get, usually in kids, I try to order as minimum amount of labs as possible, just because it's not helpful a lot of the time, because kids are pretty healthy usually. But I will get a couple things to kind of risk stratify her for her sepsis. There we go. And then I don't think she needs any of this stuff. We'll get blood cultures. And I think that's probably it on here. And then obviously we're going to get a chest x-ray. Do the least amount of things you can in kids. And then we will just go forever. Good. I don't work until Thursday morning, so we could be here until Thursday morning. I think I just have like one meeting tomorrow, so it should be fine. So that's a big guy right there. It looks like kind of both sides look a little crummy, but that looks bad right there for sure. So yeah, pulmonary opacity obstructing the left heart border. I need to change this to hard so that I don't get any advice from anybody. All right, so it looks like there's pneumonia on there. The blood culture is negative to date. So usually it takes like 48 hours to have a result on a blood culture, but in this game, we get them immediately. So she doesn't have bacteremia. LFTs are normal. Lactate is elevated. So lactate is interesting. It's kind of a marker of how bad your sepsis is. I actually don't know in kids if there's a cutoff for mortality, but in adults, actually, once you start getting over a lactate of 4, it's a big predictor of like how bad you're going to do. I'm sure there's a similar number in kids. I just don't know what it is off the top of my head. Full PCR, Brendan, that's a good idea. I think I just ordered flu, which was positive for influenza B. There you go. Okay, and what else is in here? Does she know Andrea Tully? I don't think so. I don't know. Maybe I'll have to ask her. Here, I'll message her right now and say, do you know Andrea Tully? Let's see. I'll let you know what she says. She is going to the dentist today, though, and she was very nervous about it. So I'm not sure if she's going to respond to me anytime soon. All right, investigation. Go back to this. All right, so bicarb is a little low. So in kids, we kind of use that as a marker of dehydration, and then creatinine is a little bump. So to have a kid to have a bump in their creatinine, they have to be pretty significantly dehydrated. So I'll start this kid on a my wife said she does know Andrea Tully. Well, I don't know who Andrea Tully is, but apparently my wife knows who she is. Okay. All right, so let's see. I'll put her on some maintenance lactated ringers because she's pretty dehydrated. There are focal B lines present at the left lung base. All right, there we go. That's what I'm talking about. These are, so ultrasound's great for pneumonia. Actually, ultrasound is better for detecting pneumonia, especially in pediatrics, than chest X-ray. So I like that they have that in there. Blood sugar's fine. What does magnesium tell us? In this case, not much. Probably a good point. Maybe an unnecessary lab. I didn't have a good reason. Oh, she's a popular ophthalmologist on social media. She probably doesn't know her in real life then. She just said yes. I gave her no context, so she probably just responded yes. All right, cool. Well, I think that's pretty good. So let's do our interventions. So anybody have, I'll order some other stuff. Anybody have antibiotic recommendations for this kid? And do you think I'm going to be admitting this kid or discharging her home? So let's see. I already gave her, so do I need to contact anyone? No. I already gave her Tylenol. What other stuff? I already gave her fluids. So really the only other thing I'm going to be giving her is antibiotics. So hopefully I've given you guys enough time to maybe decide on some antibiotics. We'll scroll through some options here. So we think this is, for O2 is good, probably discharge. So I would say she gets admitted because I think she has septic vitals. You know what I'm thinking now though is she did have a flu positive on her investigation, right? But usually you don't get an infiltrate with flu. So given how sick she is, even though she's flu B positive, I'd probably put her cap on top of it. Z-Pack is an okay-ish answer, but actually the rate of strep pneumonia that's actually resistant to azithromycin has gotten way, way up. So you actually need something on top of the Z-Pack. So I would probably, usually when I admit people, I give them IV stuff. So I'll probably give her PO, azithromycin, and I will give her a cephalosporin, probably IV ceftriaxone. We will see what they think about my antibiotic choice. So I'll give her azithromycin PO, and then I'll give her some ceftriaxone IV. And I think I'm good with that. She is going to be admitted to the PICU or the floor. I think she's on oxygen. So this is very dependent on your, whatchamacallit, like the hospital you work at. But here, I think the floor is going to be fine. My wife's typing more to me now. I met her at Columbia. My wife was at Columbia for a little while. So apparently she met her at Columbia. I didn't know. She's an ophthalmologist from Columbia, I guess. So let's see if flu is on here. So influenza, yep. So I add that to my differential. We are going to say this patient has pneumonia and flu. They also have sepsis, though. I think this is right. You guys feel good about this? I feel good about this. Kids with flu and pneumonia can get bad. I agree with that. Hand off. You have incomplete interventions. Oh, shoot. I didn't click do the interventions. Wait, hang on. I forgot to click do these things. Perform. Give my antibiotics, please. Do they give them? No one told me anything. Probably fine. Hand off. Diagnosis of the community. Yes, I'm sure now. Caleb, yes, you could use Doxy. I think that's another good choice, but usually I use Doxy PO outpatient. I don't have a good reason why I use dual coverage inpatient and Doxy alone outpatient. I think Azithro does have a little better atypical coverage than Doxy. Granted, her chest x-ray didn't look like an atypical pneumonia. It looked like a lobar pneumonia. Ooh, it did not like, well, let's see what it says, because it says my interventions are 20%. So apparently it didn't like my antibiotic choices. Unnecessary. So why are they saying, aha, interesting. So this is an anti-flu medication. So I do not give Tamiflu, that's what this is, super frequently. It's true that it is a CDC guideline recommendation, and I think especially in the pediatric population, they like to give it more. But the studies on Tamiflu, basically, it doesn't really do anything. So I kind of don't give it frequently. That being said, they are right. It is part of the CDC guidelines, so I probably should have given it. I definitely should have given it, but I don't give it frequently because the research says it doesn't really work. Vancomycin, now that is something I do disagree with here. So basically, their logic here is right. So when you have an infiltrate, but it's with a flu, it's a lot of times it's MRSA. But the problem is it's usually post-viral pneumonia. So it's not usually like active while you're having active flu influenza, you get MRSA on top of it. So usually I don't cover for MRSA just empirically, unless this was like a clearly had an effusion plus they had a MRSA positive swab or something. So I still would stand by my choices here, but this is not an incorrect kind of thought process. An infiltrate on influenza positive person, a lot of times you should consider MRSA. But I just don't think MRSA stands for methicillin-resistant Staphylococcus aureus, if you guys didn't know that. But I just don't think it's the case here. Okay, so everything else, investigations, they give us 77. We didn't need LFTs, apparently. Is there anything we missed? Oh, I didn't order CBC. Whoopsie. I didn't notice I did not order that. So CBC, obviously, and they felt neutral about those things. And then all these other ones were 100%. So that's pretty good. All right, cool. Let's see. Amy Beth says, I thought it had to be in 48 hours from symptom onset. Yeah. I mean, I don't know off the top of my head. So post-viral MRSA pneumonia, I kind of understood it as you get viral pneumonia, you mostly recover from the viral pneumonia, and then all of a sudden you get way worse. You have a large infiltrate on your chest X-ray. Usually you have an associated pleural effusion, and then MRSA should be considered. That being said, they said I should give it. So, oh, sorry, Tamiflu. Amy, yes, you are completely right. Tamiflu. Yes, Tamiflu is only supposed to be given 48 hours, but the CDC does have separate recommendations for like kids of any age group. We can look up their recommendations too, but they say like basically a lot of other people should get Tamiflu. Yeast infections on antibiotics is more of a concern when doubling them or same amount. Is it common to get yeast infections on antibiotics? Is this more of a concern when doubling up on them or same amount of concern? I wouldn't say it's like super common, but it happens for sure. And it also depends on where the yeast infection is. So basically what you kind of always have to consider is antibiotics will basically kill off like bacteria, good and bad. And then so a lot of times places where yeast naturally lives, the yeast will kind of will overgrow in those areas. So like, the vagina, skin folds, things like that. The diagnosis. Oh, I thought we got the diagnosis right. Didn't we? I didn't really pay attention. I think it was pneumonia and flu. Yeah, cool. Well, it's already been an hour. What do you guys want to do? Do you want to, you want me to be done? You want to chat about some things?
If there's more questions you want to go through, you can go through them.
I mean, there is 122 cases on this, so I figured I'd just be done after like an hour or so. But like, I don't know if there's any other questions in the chat about like life or emergency medicine that I missed. You see, I can stop. And also, I guess we could show some random ultrasounds. Is there any ultrasound stuff you guys want to see? We could talk about anything.
All right, it might be the lag, but I'm not seeing any more questions.
Yeah, I don't see anything else either. Let me see. I'll scroll up. I didn't see anything. Someone asked, what kind of activities did you do in college to appear more competitive? I didn't really do anything specific. I mean, like I played water polo and stuff in college. I didn't really do anything like to really try to set myself apart. Yeah, that was about it. I mean, I don't know. I feel like I did a lot of random stuff, but probably nothing too important. All right, so here we have some stuff, I guess. Was there any other specialties you considered in med school? I'll stop sharing for a second, and then I can share again if we have like whatever. All right, so okay, now there's like a lot of questions. So were there any other specialties you considered in med school? So I kind of wanted to do surgery at first. I thought I was somewhere between surgery and emergency medicine. And then I realized like the life of surgery was like kind of not what I wanted my life to be like. And surgeries are really long and I can't really focus on anything for more than 15 minutes. So I did not do surgery after that. All right, let's see what else we got in here. Have you ever delivered a baby? Yes. So in residency, you have to do 15 deliveries, like to kind of get checked off. But that being said, after that, I've never delivered a baby outside of OBGYN, like rotation in the like OBGYN suite. I have not delivered a baby in the ER. So I've delivered 15 babies in the OBGYN suite and nothing after that. Do you do surgeries, procedures often? You never do surgery. Wow, there's a lot of questions. Sorry, guys. Do you never do surgery? So we do a lot of procedures though, like incision and drainage, obviously intubation, chest tubes, a lot of stuff like that. Lumbar punctures. I think I saw like some other ER people talked about some of the procedures, but there's a ton of procedures. Basically, whatever your comfort level is with a procedure, if it's needed to be done like emergently, you do it in the ER. That's basically how it goes. And so if there's ever something that's about to kill someone, you have to fix it. Unless you can call someone else to help you. And if you're out in the middle of nowhere, you're not gonna have any other help. Oh, sorry, my puppy's back here doing something. I just heard him. How do you manage to study for the MCAT while doing undergrad? In all honesty, like I didn't study super duper hard for the MCAT. I think I got like an average score on it. I mean, sorry, that's not great advice, but yeah. What made you go into medicine in general? So the reason I kind of went into medicine is my mom was a nurse. She kind of grew up around medicine. And then during college, I took like right at the end of high school, I took an EMT class and I thought it was really cool. I never really worked as an EMT for like 2 months. I worked as an EMT. And then it was like making way less money than I made at Chili's. So I just went back to working at Chili's. That it kind of just inspired me. I was like, wow, this is super cool. I actually started at the community college I started off like a nursing track. And then I realized in California, the schools were like so impacted. Everything was taking forever. I realized it was going to take me forever. And so I just decided I would try to get like a biology degree and go to med school instead. Let's see. What's been the most eye-opening thing you have experienced in the ER? I mean, I think that in general, the ER really exposes you. I think as a physician, an ER makes you like really well-rounded on a personal level because you experience like these people that are like at their wits' end with society. They're homeless. They have no money. They have no family support. They have no social support like whatsoever. And they're basically coming to you like with their like, their pockets turned out and they're like hands up, like, what can you do for me? I need help. And you also have these people who are like so affluent and they come in and they're like VIPs and they're like, I need my CT scan done right now. So it really gives you perspective on like society in general and just like how life works, to be honest. So, I mean, I think ER is like one of those things where you're never going to experience something where you have such a like vast view of society in one career that you can really understand like where anyone's coming from, because you see it every day. You think your experience is DO education in your work experience? Let's see. Do you think your experience in your DO education that helped you in your work experience? No, I mean, I think med school is good. I didn't really like OMM, which is like the osteopathic manipulation medicine thing that the DOs are known for. I didn't really like it. It wasn't my thing. I think it helped me learn anatomy a little better. I never use it anymore. But it's fine. What kind of research do you get into as an emergency medicine doc? I just kind of do whatever. Right now I'm doing a lot of COVID stuff. You guys may or may not have seen some of my publications about like the COVID vaccinations and stuff, but I have like a preprint out right now about like COVID vaccines in Michigan and stuff, but I kind of just do a lot of research. What was your residency schedule like? So every residency schedule is a little different. Mine was 12-hour shifts. We did 18, 16, and then I was chief my senior year, so I got 14 shifts a month. Pretty busy on ER months, but you have basically half the month off. If you're working 15, 16 shifts a month, the other like 14 days you're off. So it's a very nice schedule in that regard, as far as like you're not there Monday through Friday and some weekends, which is like the majority of residents. What was the one thing you wish you would do different in emergency medicine? Probably like what I was referring to before. Like, I think that some more equity, health equity is like what really is needed in this country, and especially in emergency medicine. Like, I don't want to have to consider like a patient's insurance and like what they can and can't afford to get done. Like, I want them to come to me and I want to say, this is what's best for you and this is what I want to do for you. So I think health equity is like something that I would want to change in emergency medicine. I did a little research in undergrad. I was like pretty into like bench stuff. So I got like one publication and then did like a lot of like research activities, but nothing like crazy. My CV before I got to like residency was like not anything insane. Yes, I applied to both MD and DO schools. And then, like I said early, Valerie, the DO decision was just because I didn't get into any MD schools in Southern California. And I basically wasn't really willing to move out of Southern California because like my family and my wife. So how did you prepare for your first year in medicine, and how were your USMLE? So first year in medicine, I think I like to study ahead of time so that like when I'm in the moment, so this is like kind of my philosophy when it comes to working and stuff, is that there's so much you have to learn like on the job, where things are, how to do X, Y, and Z, that if you don't already kind of know the medicine, it's really hard for you to learn the medicine on the job. So I spend a lot of hours outside of work studying whatever kind of like I don't know, realm I'm in. So like my critical care fellowship starts in like a year basically from now. And so like this next year, I'm going to focus on trying to tackle like a lot of critical care review and stuff so that I can really, when I start fellowship, focus on like those physical aspects of the job that are also hard to get. So I study a lot like outside of work. I think that's important with basically anything. Like you can't just go to lecture in med school and expect to pass. You have to study a lot outside so that when you go to lecture, it's useful. You're actually absorbing something. It's the same at work. You have to study a lot outside of work in medicine so that when you go to work, you're absorbing stuff rather than just being like blindsided by a bunch of patients. Because as you just saw, it comes at you like lightning fast. Like you walk into a room and someone's about to die. And so you just have to be like, all right, let's go. Let's do this. Do you have any preparation tips for the MCAT? No, sorry. Actually, the MCAT's even changed a lot since I took it. And I was like, whatever, like, I don't know, 9 years ago, 10 years ago or something. So I don't, I'm sorry. What's the most interesting thing you've seen while working? I don't know. There's a lot of interesting stuff that comes in the ER. People shoving things in their orifices that shouldn't be there. Traumatic injuries, unfortunately, from car accidents and stuff. There's a bunch of interesting stuff. How do you deal with patient deaths in the ED? So that is an unfortunate part of medicine, I think, for everybody. And you really just have to kind of remember that like these are people, because at some point it's hard to remember that sometimes. Like you see numbers, you see vitals, you see labs, you call consultants, and at the end of the day, if someone dies, like this was like somebody's loved one that died. And so when it comes to like death and disability, you really have to like circle back and remember your humanism and say, this is a patient that's in front of me. How would I want to be talked to if my family member just like passed away in the ER? How would, I want my mom talked to if this was me that died, if I was a young kid in a car accident or something. So I think that's kind of how I approach it. It is a hard topic though, for sure. Are you a gamer? Yes, I am a gamer. My setup here, I don't know. I have like my gaming headset over here. I have a giant computer. Obviously, I have 2 monitors. So yes, I'm a gamer. Any advice for med school interviews? Med school interviews are different than residency, but I would say just be yourself. If people like you, they're gonna want you to be part of their little cohort. So just be yourself. And if they don't like you after your interview, then it's not somewhere you want to be. That's kind of how I feel about it. How do you do research opportunities in med school? Do you have them going on to find doctors in the community? I mean, that's like pretty aggressive to go out and find people to do research with you, but it's kind of like, it's kind of like one of those things that people work really hard and they get to like, Harvard or wherever they want to be, or they work really hard and they don't. And it's unfortunately that's just like supply and demand. And I think, you just have to decide everything in life. You have to decide how important it is to you. If you want to spend all those hours studying and doing research and all the stuff that you don't enjoy to get where you want to be, then that's fine. But if you do enjoy them, then just do them because you enjoy them, and then you'll get where you want to be. But in my opinion, you have to have a balance between working hard and doing stuff that you don't want to do to get where you want to be, and just enjoying your life. So, if it was me, I would prefer to have, done what I did. I didn't do too much crazy studying for the MCAT. I didn't do a ton of crazy research and stuff because I enjoyed my life outside of school a lot. And I just wanted to, go to school. And where I went wasn't important to me. I just wanted to stay in Southern California and be with my family. Oh, thanks. You're going to follow me on Instagram. A Little Cold Gel is my Instagram. It's kind of anonymous, except I posted a thing about this today. But clinical hours in undergrad, I don't know. I didn't do a ton. I kind of shadowed a couple doctors that I had in the area. I don't know how many I did exactly though. Yeah, I mean, ER doctors, I think they get sued a lot. I've never been sued personally. I know some colleagues that have been sued. I think, unfortunately, it's just a part of medicine, practicing medicine in this country is getting sued. What's been your most rewarding part of your journey in medicine so far? This last year, looking back on this last year, I got to do a lot of teaching of residents, and I got to do a lot of education and stuff that I really enjoy. And I think the most rewarding part so far is kind of coming to this, I would say almost like a climax of my education. It's like I'm here now, and I can do all the stuff I want to do kind of without anyone else telling me what to do. And I'm just basically in love with my job every day. And it's amazing. I think that, you grind and you get so focused on accomplishing the next task and just doing everything. But people talk about we're missing the best part of our lives. We're our 20s and stuff when we're in med school. And it's all these memes about, I'm so sad going to work and crying every day. I get it. I sympathize with those hours. I've been there studying and all that stuff sucks. But at the end of the day, I'm in this position now where I'm working 8 shifts a month. I'm making more money than I need to live. And the rest of my time I spend doing all the other stuff that I love to do. Granted, the other stuff I love to do still revolves around medicine. But I mean, if it didn't revolve around medicine, I would be out kayaking and I don't know, doing stuff that other people do. But I just love this medicine stuff. So this is what I do in my free time. But I mean, I think that's kind of where I'm at is I love my life right now. Let's see. My hobbies. So yeah, I do play video games and stuff. I go geocaching sometimes. My wife has tried to make me play tennis. I ride the Peloton a lot. Let's see, my dog's names. I have Thomas Jefferson and Benjamin Franklin. They just call them Tommy and Benji. What is your greatest struggle as a pre-med? I don't know. I guess balancing work and school and stuff. And so, I mean, I don't know. I think balance, it was hard as a pre-med for me. I didn't really party or drink or anything too much when I was a pre-med. So that wasn't too hard. It was more social stuff with commuting to school, playing water polo, just kind of balancing those things. Let's see. Yeah, I mean, the most competitive residency stuff, I think that you can basically look up all those stats online. There's whoever it is publishes every year all the step scores and how many publications you had and all this stuff. But that being said, at the end of the day, like I was saying before with the interviews, people want people that they like and they know. So if you want to go somewhere for residency, go there, show them that you're interested, show them that you're a cool, normal person. And it probably won't matter that much how much research you've done. If you're a likable person and you work hard and you have passed all the classes, they'll probably take you. But it's just hard to get that FaceTime sometimes, I know. How important is shadowing experience for med school? I think it, again, depends on the med school. Some really probably care, some probably don't care at all. Thanks for that. How many hours will the shadowing session count for? I have no idea. The web shadowers. 1.5 hours. I'm still here. Sorry, guys. All right. Well, we can end this. And you guys can ask me questions I guess I could just go live on my own YouTube channel. You guys could ask me questions. I don't want to I know you guys have to stay here or whatever for the Google thing. So I don't want to keep you, anyone who doesn't want to.
Alrighty, so it seems like we are finishing up here. Thank you very much for presenting for our web shadowers. We loved how entertaining and interactive the session was. Everyone, please make sure you check out his socials to learn more from him. His Instagram is @littlecoldgel. The link to today's Google form has been posted in the the chat box, and will be posted in the description of the video shortly. Please fill it out within the next 30 minutes for us to receive verification of your attendance, and we hope to see you all next week.
Cool. Thanks, guys. It was nice to meet everybody, and message me on